Hi, my name is Tiffany Geisler, and this is my presentation for my scholarly project titled Decreasing Hospital Readmissions for Patients with Heart Failure. On this slide, I would like to thank my DNP committee for their contributions and support to my project. My chair is Dr. Teresa Gallicados, Associate Professor at Maryville University. My community person is Dr. Lori Arney. And the second reader is Dr. Maria Snell, Associate Professor and Director of the DNP program at Maryville University. This slide is a little bit about my background. I received my bachelor's degree at Southwestern Oklahoma State University in Weatherford, Oklahoma. I received my master's degree at Maryville University in St. Louis, Missouri. I will now receive my Doctorate of Nursing Practice degree at Maryville University in St. Louis, Missouri. I currently work as a nurse practitioner in geriatric primary care. I chose this project because I have an interest in heart failure patients, specifically in the geriatric population. I have a background working in the cardiac catheterization lab in nuclear medicine and on the cardiac care unit. Here's an introduction to my project. Heart failure is one of the top 10 most common reasons for hospitalizations in patients older than 65. These patients have a 20% risk of rehospitalization within the first 30 days of discharge. The purpose of this scholarly project was to determine if certain interventions, including home health, medication reconciliation, and early follow-up, decreased rehospitalizations for patients with heart failure. The aims were to implement strategies shown to decrease rehospitalizations. This slide shows my DNP question, which is, in patients with heart failure, how do implementation strategies such as home health, early follow-up with medication reconciliation, and acute exacerbation of CHF treatment compared to standard care impact rehospitalizations over a 12-month period? Next is the theoretical framework. This DNP project included outpatient implementation strategies and was best represented by the Iowa model of evidence-based practice to promote quality care. This model involves a problem-solving approach. Again, the problem is rehospitalizations of heart failure patients, and the problem-solving approach is outpatient treatment interventions. Next is a review of the literature. There were 10 articles that were chosen, and they were grouped into the following 3 themes: early identification of symptoms, provider follow-ups with medication reconciliation, and home health monitoring. Many patients have precipitating factors leading to an exacerbation of heart failure, including comorbidities, poor drug compliance, inadequate treatment, or lack of social support. One study found that establishing successful contact within the first 3 days after discharge led to better outcomes. Frequent contact within the first 14 days allows opportunities for home health nurses to identify developing symptoms or changes with the patient. The early identification would also include the follow-ups with medication reconciliation, patient education, optimization of medical treatment, and psychosocial support. Medication reconciliation completed within the first 48 hours of discharge results in a lower readmission rate. Proactive monitoring of patients in the early discharge period can identify clinical symptoms or needs to help decrease that risk of readmission. One study found that 50% of hospitalizations occurred within the first 14 days. Hospital visits completed within the first 7 days after a discharge had better outcomes. Most initial home health visits were completed within the first 2 to 3 days after a discharge, and these studies showed that the scheduled home health visits allowed for monitoring of the patients and had shown improvement in the patient's self-care behaviors and their ability to follow, adhere to treatment, improve their quality of life, and increase their knowledge of the disease and reduce incidence of readmissions. The early and frequent contact allowed the staff to get to know the patient and have a better baseline for that patient. Next is the methodology. Prior to this quality improvement project, there was not a set protocol to follow to reduce heart failure readmissions. To consistently implement the current practice guidelines and improve patient outcomes, a quality improvement program was implemented at the clinic, at the outpatient clinic. And then the design for the project. This project was a quantitative exploratory design that utilized a retrospective chart review to analyze the impact of the program interventions. A pre- and post-intervention design was employed for the purpose of this project. The project was implemented by identifying elderly patients with heart failure and following those patients for further acute exacerbations within the first 30 days of hospital discharge. IRB approval was obtained by Maryville University, and then the data collection commenced. On this slide, I've included the inclusion and exclusion criteria that was applied during the EMR review. Next is the data collection. Data was collected from 62 eligible EMRs for patients with heart failure who had been admitted to the hospital. All data was de-identified and entered into a data collection sheet. Only the minimum necessary data was collected. The time frame for the pre-intervention data was January 1st of 2022 through December 31st of 2022. And then the post-intervention time frame was January 1st of 2023 through December 31st of 2023. The data collection instruments encompassed information retrieved during the pre- and post-intervention period. The data collection sheets included pertinent information such as age, gender, and if the interventions were completed or not. All data was nominally coded using a 1 for yes or a 2 for no. The sample consisted of 16.7% or 10 male patients and 83.3% or 52 female patients. Medication reconciliation was completed for both groups at 100%. There was no home health in the pre-intervention group, and 74% of patients received home health in the post-intervention group. 32% of patients in the pre-intervention group adhered to their follow-up appointment, compared to 90% of patients in the post-intervention group. The 2 sample z-test of proportions was used to determine whether the two populations differ significantly on specific characteristics. This test was used to determine if there is a statistically significant difference between the pre- and post-intervention groups. Next is the results. The pre-intervention group had statistically higher readmission rates at 0.39 than the participants in the post-intervention group at 0.16, with a p-value of 0.02231. The z-test for the difference of 2 proportions revealed that early outpatient interventions after a discharge proved effective at reducing rehospitalizations when compared to the prior year before interventions. Next is the interpretation of the results. The expected outcome was a decrease in rehospitalizations of patients with heart failure. and there was a statistically significant decrease, as seen on the previous slide. The outcomes of this project were beneficial to the outpatient clinic. The data collected proved that the outpatient protocol implementing treatment interventions following discharges of patients with heart failure decreased rehospitalizations. The communication between the interdisciplinary team helped facilitate the success of this project. The results of this project may have continued positive outcomes for this outpatient clinic. And then changes to improve the future outcomes include adding appropriate education for the patients and caregivers that will encourage seeking early outpatient treatment. Additionally, adding structured phone calls at regular intervals by nurse case managers would increase adherence and adherence to medications and follow-ups and adherence to follow-up visits. Next is the discussion of limitations. There were only 62 EMRs for this project, so it was a small study. This study only looked at patients that were hospitalized with acute heart failure, so we didn't look at the all-cause readmissions for patients with heart failure. The results can be generalized for the elderly population with a diagnosis of heart failure given the z-value of negative 1.99 is below the critical z-value. Limitations were minimized by rigorous data analysis and interpretation. The limitations did not compromise the overall intent of this project, and in the future will be useful when designing post-discharge protocols for patients with heart failure. Next is the implications. So for future changes, consistency of utilization of the outpatient discharge protocol is likely to continue to improve outcomes of decreasing rehospitalizations for patients with heart failure. And then again, adding the appropriate education and the structured phone calls will also help with reducing rehospitalizations. Next is healthcare policy changes. Does reimbursement affect the care? One article stated that there are several different payment methods. The one that we all know is the fee-for-service reimbursement. Other payment models include the value-based model and a prospective payment model. The question is whether or not this system disproportionately penalizes outpatient clinics caring for highly medically complex patients. Another policy change would be to provide transitional care management. One study found a statistically significant decrease in rehospitalizations in patients with heart failure at 9.1% when compared to the pre-study cohort of 14.3%, and that was using transitional care management. Next is quality and safety. Reducing hospitalizations for heart failure is one of the objectives of Healthy People 2030. The American Heart Association has guideline recommendations to help prevent rehospitalizations. This quality improvement project follows current quality and safety guidelines for patients with heart failure. The outpatient clinic that this project took place has nurse case managers that can implement phone calls to recently discharged patients. This will enable improved adherence to medication regimens and follow-up appointments. Furthermore, improved communications with admitting hospitals can improve continuity of care. Next is the benefits of the project. So decreased cost. Hospitalizations due to heart failure make up 65% of all medical heart failure costs over a 1-year time period. One study found that the median annual cost for a patient with heart failure without hospitalization is around $25,000. When we add in hospitalization over 1 year, that cost is around $100,000, and that's just for one patient. Utilization of the outpatient interventions for patients with heart failure is needed to reduce mortality rates and decrease costs. All patients have interactions with the interdisciplinary team multiple times per month. It is quick and easy for a nurse to identify signs and symptoms of heart failure and relay this information to a provider. The implementation of this project may show a reduction in hospitalizations linked to decreased mortality and decreased costs. Finally is the conclusion. Heart failure in the elderly population can have devastating effects. Early outpatient treatment interventions for patients with heart failure are important in reducing rehospitalizations. The recommendation is continued consistent use of the outpatient discharge protocol. This quality improvement project has shown a great benefit to the selected outpatient clinic. The results of this project demonstrated that early outpatient interventions can decrease rehospitalizations. This project's outpatient discharge protocol can be used for all hospital discharges. And the plan for sustainability is to have the discharge protocol built into the EMR. Additionally, nurse case managers will be provided education and will call patients at regular intervals after discharge to encourage adherence to medication regimens and follow-up appointments. And then lastly, the plan for dissemination. The plan for this quality improvement project for dissemination is to share the project poster with healthcare providers that care for the geriatric population. This outpatient clinic is a part of a national association with similar clinics and will be shared with the clinics in the association. I would like to thank everybody for listening to my presentation for my scholarly project, which is decreasing hospitalizations in heart failure patients. If you have any questions, please feel free to email me. I've included my email address on this slide. I have also included the references for my project. And again, I would just like to thank you.